Today, I'll talk about some aspect of endoscopic diagnosis of gastric cancer. Today's topics. Let's think about the concept of early gastric cancer. Gastric cancers can be divided into EGC and AGC. EGC is a gastric malignancy that is limited to the mucosa or submucosa, irrespective of lymph node metastasis. In contrast, AGC is a cancer invading proponous layer or beyond. Lymph node metastasis itself has nothing to do with the definition of EGC or AGC. EGC can have lymph node metastasis. According to a recent meta-analysis, the risk of lymph node metastasis is 6% for mucosal cancers and 28% for submucosal cancers. This is an example of lymph node involvement in a small mucosal cancer. In the screening endoscopy for a 66-year-old male, a flat hyperemic lesion was found, and the biopsy was moderately differentiated adenocarcinoma. ESD was done as usual. Circumferential cutting, submucosal dissection, final image, resected specimen. But the ESD pathology was mixed histology with lymphatic vessel involvement. The depth of invasion was muscularis mucosa, and the tumor size was 26 millimeters. D240 immunohistochemistry. You can clearly see a lymphatic vessel invasion. I recommended additional surgery. In the subtotal gastrectomy specimen, there was no local residual tumor, but there was a lymph node involvement in the greater curvature lymph node stations. In this low power image, it is difficult to find lymph node involvement. However, in the close-up, you can find malignant cells in the subcapsular sinusoidal space. This is another example for submucosal cancer with lymph node metastasis. After ESD, surgery was done. There was a clear big metastasis in one of the number 3 lesser curvature nodes. This is a close-up. Why do we use the concept of EGC in the TNM era? Endoscopic findings of EGC are quite different from AGC. In the screening endoscopy, finding early gastric cancers have great impact on the outcome. The indications of endoscopic treatment are based on the endoscopic assessment, especially depth of invasion. Early detection of gastric cancer is so important for less invasive treatment. At my institution at Samsung Medical Center, gastric ESD is done about 1,000 cases a year. In the recent 5 years, the rate of gastric cancer among ESD cases was 73%. The rate of additional surgery after ESD for gastric cancer was 15%. For the selection of ESD candidate, endoscopic assessment of early gastric cancer is so important. Endoscopic findings of EGC. EGCs can be classified into type 1, 2A, 2B, 2C, 3 based on endoscopic findings. Type 1 and 2A are elevated EGCs. Type 2B is flat EGC. Type 2C and 3 are depressed type early gastric cancers. The distinction between EGC type 1 and 2A is not clear. A 2.5 millimeter cutoff limit was suggested in the updated Paris classification, but it is difficult to apply in the real clinical practice. Instead, I'd like to show you some examples. What do you think? This is an EGC type 1. What's your opinion? This is also EGC type 1. What about this case? My opinion is EGC 2A. Okay, you can say 2A plus 2C. But in the classification, the simpler, the better. What's your opinion? I think it is a 2A plus 2C lesion. EGC 2A to B 2C are all superficial cancers, but EGC 2B is a truly flat type early gastric cancer. A small, flat, discolorated lesion was found in the screening endoscopy of a 45-year-old male. We repeated endoscopy for the possible endoscopic treatment. There was no atrophy and no evidence of Helicobacter pylori infection. The pathology was poorly differentiated carcinoma signal ring cell type. ESD audidon, and the final pathology was signet ring cell carcinoma within the lamina propria. Currently, a prospective clinical trial about ESD for undifferentiated type early gastric cancers, ERASE GC trial, is ongoing in Korea. This is the current status of patient enrollment of the ERASE trial. The target is 708 patients, and more than 500 cases were enrolled right now. Depressed type EGC, type 2C and 3. These are typical endoscopic findings of depressed type early gastric cancers. The edge of the depressed area is unclear, irregular, moss-eaten, and sometimes focal regenerative epithelium and mucous overriding can be seen. The base of the depressed area is uneven and mostly covered by white exudate. This is an example. How do you describe the findings. The edge was blurred and irregular, and the base was uneven, and pale discoloration is seen. Neighboring fold showed traction into the depressed area. Fold traction is caused by desmoplastic reaction, submucosal fibrosis under the depressed type early gastric cancer. These are typical fold changes in early gastric cancers. For mucosal cancers, you can see interruption and rapid tapering. For submucosal cancers, you can see clubbing and fusion. In this small submucosal signal ring cell carcinoma, you can see a lot of fold changes. How do you call it? I can see abrupt cutting, rapid tapering, and fusion. Asymmetrical fold change is also a sign of malignancy. Can you see some fold changes in this case? Normal gastric folds were cut by the depressed type early gastric cancer. This is a superficial spreading type early gastric cancer. The size of the lesion was 7 cm in diameter, but the tumor was limited in the mucosal layer. Total gastrectomy was done, although there are some areas of submucosal desmoplastic reaction. The tumor is limited only in the mucosal layer. This is a relatively depressed area with a thin mucosal neoplastic tissue. And this is a relatively thick neoplastic mucosal area. Minor blood oozing can be a sign of malignancy. Helicobacter pylori is commonly found in gastric cancer patients. You can see prominent lymphofollicular gastritis in the antral mucosa of a lady with a submucosal cancer. Gastric cancers can develop in the background of atrophic gastritis. When there is a focal non-atrophic area, it can be EGC to B or to C. In the ESD specimen, it was a 30 mm sized lamina propria cancer. A tiny discoloration may be seen, may be an important clue for the diagnosis of EGC. Actually, in this case, the slightly depressed red area was only part of the EGC to B plus 3. Only part of the EGC to B plus 2C. The upper cut shows a relatively depressed lesion to C area, and the lower cut is a relatively normal looking part to B area. In the relatively normal looking area, you can see a lot of isolated single cells spread between the normal gastric pits. How accurate is the endoscopy in the differentiation of EGC and AGC? About 3 to 8% of endoscopically suspected EGCs are actually AGCs in the final pathology. We need to know endoscopic findings of early gastric cancer for this purpose. A small elevated lesion with slight surface hyperemia was found in a screening endoscopy. The biopsy was moderately differentiated adenocarcinoma with suspicious lymphatic tumor emboli. What's your opinion about the depth of invasion? Final pathology after surgery was a proper muscle cancer. The tumor was mostly located in the submucosal layer with some proper muscle invasion. The overlying mucosa was partly normal with minor areas of cancer. So this is a typical case of EGC like AGC. The Bowman type is tricky, but our pathologists say it is a Bowman type 4. Next topic is endoscopic findings of AGCs with emphasis on Bowman type 4. Why Bowman type 4 is so important? Endoscopic diagnosis of Bowman type 1 to 3 is rather simple and easy. Biopsies for these lesions are mostly positive for malignancy, but Bowman type 4 is easy to miss, and biopsies for them are negative in many cases. So I can say that Bowman type 4 is the key of endoscopic diagnosis of advanced gastric cancers. A 59 years old lady was referred for the further evaluation of suspicious Bowman type 4. Initial endoscopic biopsy at local clinic was negative for malignancy. In the endoscopy at my clinic, gastric fold looked thickened. Even after air infusion, the gastric body did not expand very well, and the border between lower body and antrum was narrowed. There was a small ulcerative lesion at the narrowed segment. The biopsy was signet ring cell carcinoma. Biopsies from thickened gastric folds were negative. This is a CT gastroscopy image. There is a narrowed segment at the border between antrum and lower body. We call it a pseudo-pyloric ring. You can also identify the pseudo-pyloric ring in this transectional image. What is the most common finding of Bowman type 4 gastric cancer? Of course, it is a prominent fold thickening. The gastric wall itself is also thickened. Even after sufficient air infusion, the gastric lumen does not expand. There may be small ulcers or erosions. These findings are very important because biopsies from depressed area are most sensitive. Antral Bowman type 4 is one of the most difficult cases because there may be no definite mucosal lesion even after obstructive symptoms. This is a huge Bowman type 4 involving almost whole stomach. There was a duodenal invasion in the upper left image. Bowman type 4 may develop in the remnant stomach. After partial gastrectomy, the mucosa of the remnant stomach is usually edematous, so the diagnosis of abnormal thick fold is very difficult. Diffuse large B-cell lymphoma involving the whole stomach also can mimic Bowman type 4 gastric cancer. Gastric metastasis from the breast cancer may mimic the Bowman type 4 gastric cancer. Next topic is interval gastric cancer. It is very difficult to measure the sensitivity and specificity of endoscopy for gastric cancer. The reported missing rate range widely from 3% to 20%. In the Korean National Cancer Screening Program, the rate of gastric cancer is about 0.26%. In that program, the overall interval gastric cancer rate was 0.36 per 1,000 negative gastric endoscopies, 0.036%. What are the most important factors for improving gastric cancer detection rate? I think their observation of the old stomach without blind area and enough observation time. Among many blind areas, I think the posterior wall of the lower body is the most important area. An advanced gastric cancer was found in the posterior wall of the lower body. When I reviewed the previous endoscopy images, there was a small, suspicious mucosal irregularity exactly at the same area. The second most important factor is the observation time. We included 1,200 patients with gastric cancer within 6 months of cancer negative endoscopy. And we found that short observation time, less than 3 minutes, were strongly related with interval advanced gastric cancers. In order to develop a high-quality endoscopy procedural routine, high-quality training is very important, especially for the beginners. I recommended box simulator training. Don't be surprised, this is a high-speed video clip. You should do it very slowly. You can contact me anytime for the training opportunities. Thank you for your attention.